Asked to talk a little bit about congenital scoliosis, and this may feel fast, maybe more than what you want in some cases, but it's a pretty heavy topic, and I would say probably of all the cases that I do, it's either the most simplest decision making because it's a scoliosis that's going nowhere, or it's the most complicated case that I have done and probably will continue to do in the future. So kind of broad spectrum there. Let's see how this thing moves. So, what's the definition? It's basically a spinal deformity secondary to vertebral anomaly. And to be fair, it's the only, I get asked all the time whenever kids have scoliosis, if they were born like this is really the only deformity that's truly congenital, that they're ultimately secondary to, that we know are secondary from birth. Obviously, there are other kids that have some spinal deformity, but this is one that's been since birth. And there comes in two forms: failure of segmentation and failure of formation. And we'll go through a little bit about those. This is the stuff that maybe you don't want to know as much about, but basically, I think it's really helpful to understand how congenital scoliosis develops, and I think it kind of relates back to the embryology and understanding where spine is, but how everything else that gets associated with a congenital anomaly and so forth, the things that we have to look for. So basically, week 5 of embryology, you have this stuff called mesoderm, and it's the periaxial mesoderm that develops on either side of the notochord, and it forms these somites. And so these somites develop into two parts: a sclerotome and a dermomyotome. And it's the sclerotome that separates into basically two levels. And it's actually these two levels that are supposed to fuse and essentially also separate from each other. And that's ultimately what leads to the development of a vertebra. And the caudal and cephalad portions of the vertebra are basically from different sclerotomes. And it's an error in this processing that either allows for a lack of segmentation, so the lack of intervertebral disc formation, or one of these sclerotomes basically disappearing in this process and not evaporating, but basically it's lack of development that then forms a lack of formation. So the periaxial mesoderm is formation of vertebral bodies, but it's also responsible for skin and skeletal muscle. But the mesoderm is responsible for the urogenital system, pulmonary system, and cardiac system. And so that kind of lends itself to the two types of syndromes that we will frequently see, Vater and Bacterial. And so that's where those connections, if you have a problem with the formation of a vertebra, you have to think about what else is forming at that same time and what other congenital anomalies can occur. And we'll go through that a little bit later. So if we look at congenital scoliosis, the epidemiology, it's about 1 in 1,000. For some reason, girls are a little bit more common than boys. Most causes are otherwise unknown, but there's some thought that certain toxin exposure, so carbon monoxide, has been shown in a mouse model. It's been shown that happen increased frequency with maternal diabetes, certain epileptic drugs. And then there's even some question of whether there's a familial incidence or some genetic that plays a role. In general, though, I tell my families that I don't expect a sibling or another parent or so forth to have a congenital curve. So in essence, unless they have some sort of genetic syndrome that also coincidentally leads to congenital scoliosis, I don't know of an actual entity where congenital scoliosis is itself passed down. And so that's just reassuring, because we deal with the other side of the coin, which is adolescent idiopathic scoliosis, which we think is very genetically driven. And so it just allows families to either relax a little bit if they have one kid with congenital scoliosis and be not so worried about their other children. Again, we kind of talked about failure of formation and a failure of segmentation. So we'll go through that. There are different kinds of failure of formation. There's a wedge vertebra, and essentially that is just an asymmetric vertebra with one side being hypoplastic, but has two pedicles, a relatively benign condition. Hemivertebra is an absence of half the vertebra, or basically an absence of the pedicle. It can really essentially occur both in the coronal plane, but you can also have some of it in the sagittal plane. So you can have quite a bit of kyphosis associated with it as well. And we'll review kind of the treatment of this, but this is probably one of my most favorite operations that I ultimately do. Segmented failure of formation. The hemivertebra can come in multiple different forms, and it can be segmented, which means that kind of like the picture down below, if you can see my arrow, there's a disc above and below. You can be partially, so that there's only a disc on one side of it, and then you can be an unsegmented. And basically why that's important is that the growth of the vertebral body comes at the end of the vertebra. So if you have a disc, essentially you should have an apophyseal ring. That apophyseal ring is responsible for the growth of the vertebra. And that basically relates to progression. So anytime you have a curve, any type of scoliosis in a growing child, it's both the size and the risk of it getting worse that we're really, putting into our algorithm to determine whether we're going to treat it or not. So a big curve may get a treatment irrespective of whether it's going to get worse or not. But even a smaller curve that's got a high potential for growth, because there are growth plates on either side of the vertebra, is also going to be very aggressively treated. Or a small curve that's basically, unsegmented, is probably just going to be observed. There are other types of hemivertebra that you might hear about. These are kind of just board questions ultimately, but incarcerated means the vertebra above and below accommodate the hemivertebra. And essentially, the pedicles of the hemivertebra line up with the pedicles above and below. It's thought to be less risky for progression. And then there's the hemimetametric shift, where you have two hemivertebra on contralateral sides. So essentially, they're usually staggered by one or two vertebrae. Thought is that they will balance each other in terms of their progression. The problem is you can get hemimetametric shifts where they're located totally different locations. So you have one in the thoracic spine, one in the lumbar spine, and they both independently progress. And now you really kind of have two serious curves. So not all hemivertebras will balance each other, and not all of them will balance each other equally, or they'll just give two separate independent curves. So failure of segmentation, these are generally more benign. So block vertebra, the one on the pictured on the left, never anything to worry about. Those are easy. I follow them for not really the concern for a block vertebra, but sometimes when they have a block vertebra, that means they have other congenital anomalies that you may or may not see in their spine. And so I monitor them, every couple of years to make sure another curve isn't developing for some other congenital thing that I can't see on the x-ray. And then a bar, it can be problematic, depends how many vertebra, and it depends on what's on the other side of the bar. It also can result in fused ribs. So in the thoracic spine, a fused rib, in my mindset, and we've learned a lot through with development of vectors and so forth, can be as problematic in terms of its inhibition of growth on that side. And so whether the bar occurs at the ribs or the vertebra can be equally devastating. And then there's the mixed deformity, which is basically patients who have abnormalities, both formation, segmentation. Sometimes they're additive in terms of their risk of progression. You'll see sometimes they may be like in the segmented or unsegmented hemivertebra. They can somewhat cancel each other out. In terms of the natural history, in terms of the risk of progression for the kid and ultimately the problem that they may require treatment for, it's related to the type of anomaly, the patient's age or growth potential, and also the location of the anomaly. And so certain areas of the spine, such as the cervical thoracic junction and the lumbosacral junction, actually are quite problematic because they can be very clinically visible, and they can infect or they can cause the entire spine to essentially deviate. And basically the reason for that is there's no, especially in the lumbosacral, there's really no place for the pelvis to balance it out. And so the whole entire spine above it essentially tries to counterbalance that hemivertebra. In terms of the rates of progression for specific anomalies, the block anomaly, the wedge vertebra, really low risk. Again, not too worried about it. The hemivertebra, It has about a 2 to 5 degree, and this is a McMaster, basically natural history. It was done, 30 some years ago now, or almost 30 some years ago. And to be fair, it's, I guess 40 years, almost 4 years. It's stayed true to this time in terms of just really kind of identifying the patients and the type of anomalies that we're going to be running into. So a bar, whether it exists on the vertebra or it exists in the ribs, it also depends how long the bar is. So if the bar extends across multiple vertebrae, it's obviously going to have a greater effect. And there's probably nothing worse than a unilateral bar on one side with a contralateral hemivertebra. So you basically have the concave side essentially stuck from growing, and you have extra growth plates on the convex side. So that can really push that deformity and can cause the patient during their rapid growth phases to progress pretty rapidly. Some other risk factors for progression. These are the thoracolumbar region, for whatever reasons, more historical, probably relates a little bit to those vertebrae essentially grow more to the thoracic spine. Probably the ribs themselves, if they're not fused, actually provide some protection in the thoracic spine. But if you do have a rib fusion, and especially if you have, 5 ribs, for example, that's essentially 5 vertebrae that are stuck together on that concave side. Tying back to the embryology that we essentially talked about. So 60% of patients will have some abnormalities in other organ systems when they have these two syndromes. So Vater and Bacterial, you probably remember from boards a little bit, and they're associated with anorectoatresia, tracheoesophageal fistula, renal abnormalities. And then basically Bacterial adds cardiac and limb defects. And in general, these are not frequently diagnosed by us. I mean, every once in a while, I might have a patient that comes in who, has a congenital anomaly, and essentially we make a diagnosis of one of these syndromes. But the reality is usually the cardiac condition or the tracheoesophageal fistula or other things like that are presenting. And when they do come, so these Vater and Bacterial syndromes don't usually come with like a benign congenital vertebral anomaly. They usually come with the mixed deformities. So when they affect the other organ systems, they affect the spine pretty significantly as well. But if you do get a congenital anomaly like a hemivertebra or something else, there is still risk, even if it's not a really complicated or even a bar, or just there are some risks that this could have affected some of the other organ systems like renal. So in general, if I have a patient with a newly diagnosed congenital vertebral anomaly, I'll get an ultrasound of the kidneys just to make sure that they don't have any undiagnosed kidney abnormality. Cardiac, I don't send patients for echoes. I basically just refer them back to the pediatricians. Again, most of the cardiac anomalies were already picked up by their pediatricians, and so I've never made a diagnosis of a cardiac anomaly, but I have made diagnosis of renal anomalies on patients that only thought to have a congenital vertebral anomaly. And then neurologic, I pretty much will get an MRI in almost all of these patients. And up to about 35% of the patients, depending on the study, have been shown to have some sort of spinal dysraphism. And if I'm going to operate on these patients, I for surely will, because obviously the concern that we have is whether that can lead to problems with neurologic injury during the course of treatment.
You MRI the whole neural axis, right, Burt?
What?
You MRI the whole neural axis.
Oh, yeah, for sure. Yeah. So, I mean, to be fair, I don't MRI the brain, but you get like that MRI right there in the cervical spine. You got to get enough of it to know that you're not missing a Chiari malformation. And then we're all orthopedists, and so to be very fair, especially on the pediatric side, this is in your wheelhouse, right? So don't miss, a musculoskeletal anomaly. I know we're, especially as spine surgeons, and I went through the spine fellowship as well. Make sure you look at the arms and legs and things like that, and you're not grossly missing. It's not all just only about the spine when you've had the training to be an orthopedist. So just be aware of that as well. In terms of history and physical, everything that you know about whether you're assessing in peds or adults, you should, do for these patients as well. Obviously, the medical history is a little bit important in the sense that, a lot of times these patients have already been diagnosed, but just make sure that somebody's looking out for some of these other organ systems. Physical exam, similar to all the things that we would do. Again, but look for some skin dysraphisms and so forth when you examine their back. And like I said, just make sure you look at their arms and legs and all those other things to make sure you're not missing an orthopedic problem. As for neurologic, nothing special about these except for just assess the flexibility of their neck. And why I bring that up is that, interesting enough, I had just anecdotally, I had a patient that came to me after being moved or after moving from another pediatric hospital where neurosurgery did the cervical spine and orthopedics did the thoracolumbar spine. And the patient came seeing me after having surgery for their thoracolumbar congenital scoliosis. Came to see me because he was having neck pain. And when we took a neck x-ray, he had multiple congenital anomalies. None of them were dangerous or operative. And they never knew that he had a congenital anomaly in his neck as well, and had a little bit of limited range of motion. So don't be that doctor. In terms of imaging, like I said, entire thoracolumbar spine as well as C-spine. If you see some congenital anomalies, get that flexion extension views, just to make sure that, if you see some congenital anomalies, that there's no instability associated with it. I don't get CTs right away, but they are the best at defining the abnormality or the deformity. 3D CT is actually really great at doing this because it's really hard sometimes to connect on 2D where the bars and where the hemi vertebra and how they're going to affect each other. So if you're going to get a CT, especially for operative planning, make sure you get the 3D. And then you can assess chest wall deformity as well. So especially if you're thinking about fused ribs and how to manage that, especially for big osteotomies and so forth. Make sure that your CT actually includes the ribs, so you know how to handle those. And again, MRIs, we briefly mentioned, MRI all patients, entire spines, basically from the base of the skull down to the sacrum. And you want to, it's not uncommon to diagnose a spinal dysraphism. They may not all need to be operated on, but it's, especially in these complicated congenital scoliosis, they frequently have a tethered cord or something that looks like a tethered cord. Diastatomyhalia are relatively uncommon. So they're much more common in certain countries, believe it or not, but not frequently diagnosed here. And then in terms of timing, just realize that an MRI requires sedation. So just try to place it and time it appropriately from an anesthetic for those kids. And then I always order a renal ultrasound in general because kidney related issues can go undiagnosed for a long time. We'll talk briefly about surgery or management. Probably most congenital scoliosis that I see are observed. And so a lot of these bars, non-segmented hemivertebra, or even wedge and block vertebra, they don't really progress very much. Bracing, it's commonly asked, especially if you have progressive curves. It's not effective typically for the congenital component, right? So there's not a lot of flexibility in that congenital component, but it can be pretty good at compensatory curve. And so if you have a big congenital curve, you're likely going to also have a big compensatory curve, and that can be effective, at least in managing that portion. As for operative management, there are two categories, and it's really in terms of how you plan and look at it. It's prevention of deformity. It's easier to prevent it than to correct it. The irony is that I feel like as we go through this list and every time I give this talk, it's interesting how often I'm using more of the complicated management tools than I am doing the easy prevention of deformity, and you'll see what I mean. And then there's obviously correction of deformity either through acute or gradual correction. So in situ fusion, and this is the one that I always wonder whether I should be doing at some of these really young patients. And that's basically the idea of stabilizing a small curve. So if you know that the patient has a curve that's likely going to progress, why not just fuse it before they have any big deformities or compensatory curves or anything like that? Typically, a short fusion can have a very limited effect on spinal height, so I'm not adverse to performing and probably the place that is probably easiest to do it, but also because it's the most complicated to treat if it does progress, is either at the lumbosacral junction or the cervical thoracic junction. And if the patient has a bar on one side, all you need to do is put a bar on the other side by fusing it and putting some instrumentation across there, and essentially that should not get worse. And at this point in time, historically, people weren't doing it with instrumentation. I would say most people do it with instrumentation. And in the really young patient, you worry a little bit less about crankshaft phenomenon, because the reality is you're not trying to do a big, long portion of the spine. You're just trying to do a pretty short portion of the spine. And if they have crankshaft, it's probably because there's some other congenital growth congenital anomalies that are affecting growth above and below. Hemiepiphysedesis, the idea behind this is to do a kind of a short, aggressive, ideally with instrumentation fusion on the convex side, and then allow the concave side to continue to grow. This is historical, this ideal anomaly of a hemivertebra less than 50 degrees. I would say most of us would think now that a ideal anomaly is probably, again, something that's, is probably 20 degrees. 50 degrees is still a relatively big curve, and a hemivertebra is something that we would probably resect at this point. In terms of just some things to consider, you get about 10 degrees of correction in general. And even with that, it's not completely reliable. It's not very good at congenital kyphosis, so I would not consider it for congenital kyphosis. And basically the reasons why hemiepiphysedesis and in situ fusions, even though when I'm looking at a big curve and I wish that I had done it when they were young, is because if it doesn't work out well, it's actually makes it a harder operation in the future now to have, a spine that's been touched and it's fused and has instrumentation. Now you're likely going to create a more complex surgery if it doesn't work. So it's a little bit of the fear of it not working that I think prevents us from wanting to do it, and the fact that we now have more aggressive techniques and instrumentation that allows us to better correct the patients. But there are definitely some curves that I wish when they were young I had considered doing something easier. Fusion instrumentation, basically this is similar to what you would do for an AIS or anything like that. And the situation is basically you're just trying to correct a long portion of the spine, and hopefully somebody that's ready for a fusion, so kind of an adolescent or later, and using the flexibility that comes between the congenital vertebra or above and below to get an ideally straight or straighter spine. The pre-op planning would be very similar to adolescent idiopathic scoliosis, except the mindset is you're just not going to get them as straight. And you're probably going to be fusing some, otherwise normal vertebra, and it's through those normal vertebra that you're going to get most of your correction and essentially just bypass the congenital vertebra. But that's, relatively compared to the stuff that I'm going to talk about in a couple slides, is a safer operation to do, and can still give you the balance that you're looking for and the longevity for the patient. The problem is if you fuse an instrument and you don't get the patient balanced, now you've created as this patient gets older, you created a situation that's going to require a very extensive revision surgery with probably a 3-column osteotomy. So, just have that in mind when considering the treatment options. Preoperative traction, a lot of my patients that I put in pre-op traction have severe congenital scoliosis. And the idea behind this is to decrease the acuity of the correction and probably also prepare the spinal cord for what will likely become a 3-column osteotomy and an otherwise aggressive surgery. So I just did a patient yesterday with a severe congenital scoliosis, and I put the patient in traction for 6 weeks, and I got less than 5 5%, maybe even 5 degrees of correction. And why I didn't pull the trigger earlier is because I think it actually did help to prepare the spinal cord for the operation. And so I think there's value more than just correcting the deformity. And there are lots of studies now. These are some older studies, but there are lots of studies now that show that preoperative traction, even in a patient with congenital kyphoscoliosis, where we worry about kyphosis, can be very beneficial. So this is my favorite operation, and we'll go through this real quick. So basically, the idea is remove the hemi vertebra. It results typically in a short fusion. Can be done anterior, posterior, but I would say that the current method is now a posterior only procedure. And essentially, you're removing the entire hemi vertebra. In my mind, if this is the only location that the patient has their congenital anomaly and it's only a hemi vertebra, it's such a great operation because essentially you're doing a very short fusion and ultimately is a cure for this patient. It is a kind of a hemi 3-column osteotomy. So in my talks that I give about kind of the progression to feeling comfortable in doing 3-column osteotomies in the pediatric population, this is a beginner, the easy side of a VCR. And so this is really a really fun operation to do. It's not that there aren't any risks associated with it. And usually the risk is actually not a spinal cord injury. If most of the studies, the risk is injuring a nerve root because you're operating around the nerve root on the convex side. And that nerve root frequently is tethering the spinal cord across that kind of convex side. Again, anterior, posterior, but I would say now mostly it's a posterior approach and show great correction rates, greater than 66%. I mean, to be fair, I mean, some of these are 100% corrections. Then there's the osteonomy VCRs, and these are kind of salvage techniques for really rigid curves with mixed congenital and can be relatively scary operations. And then finally, these patients are born with this. And so sometimes the curves are starting off pretty severe at a pretty young age. And so you have to consider some fusionless options. And at this point in time, it really is either a growing rod type construct or a vector rib-based construct. And all the things that you probably heard about with regards to growing rods or vectors apply in this population, except for the fact that because the mobility in the congenital curve is probably not there as much, you don't. These are the patients that don't quite get the same correction that an idiopathic early onset patient would have, because again, you're only distracting the spine and correcting through the open discs, and you're not necessarily manipulating or changing the vertebral bodies themselves. It does typically result in an otherwise longer fusion, and you're doing it to avoid doing an early long fusion that would have negative effect on pulmonary function. As for the kind of two methods, growing rods, which you've heard a lot about, which were basically is essentially created by Dr. Ekbarnia and really populated by him and his organization, has been one of the mainstays for treatment of this in the early onset patient. And then Bob Campbell, his contemporary, designed the vector, which is essentially looking at a little bit more of rib-based treatment. And when you have fusions across the ribs, it can actually help to kind of distract by doing a thoracostomy. Or thoracoplasty for those fused ribs. So in general, I know we have to be done by 8 and leave some time for questions. I do think embryology is important in the spine and understanding this. And probably the most important part about it is so that you don't miss other associated anomalies. It is important when you're treating this population to understand the progression of the deformity. If you understand the progression of the deformity, you can actually choose an easier operation before the deformity gets bad. And then deformity correction is always balanced with complications. And these are the patients that are gonna probably in their most severe cases going to be the most stress. At least they're the most stressed in my practice. So. Any questions? Sorry, I kind of breezed through that pretty quickly. Hopefully most of that stuff made sense.
was awesome, Burt. Thank you. Hey, so what do you do in that sub 5-year-old with a bad congenital deformity? That seems to be progressing.
Yeah, no, I know. That's the nightmare. So I always give this, especially to the adult deformity surgeons. I personally think that the average adult deformity case is more complicated than the average, technically more complicated than the average pediatric deformity case. But I still am biased that the most complicated spine case that you can do is still a pediatric case, because it is a 3-year-old, 4-year-old with a 100-degree congenital curve. And so, yeah, you can treat them with an aggressive VCR and fuse them and keep their trunk at the size of a 3-year-old. But the reality is that doesn't provide the longevity to the patient that you want. So I think it's hard. I think we balance between if it's rapidly progressing, you're forced to do something, you're deciding between some sort of aggressive but short 3-column osteotomy that may require, I didn't put it on here, adding a Schilla technique to allow some growth potential above and below the 3-column osteotomy. You might try to add a vector to, or a growing rod to the ribs to try and slow the progression to a point where you can more definitively manage it. I would say it's not textbook, unfortunately, in that population. And so you kind of have to treat the person individually and kind of just have to see what the ultimate options are for them.
Thanks. Yeah, I would agree with you, by the way. I'll echo your thoughts. I think in general, some of the adult, more rigid deformities end up being just more of a struggle than the kids are. But when you add the growth potential to that piece and the age, I think it overwhelmingly trumps the whole thing, because the decision making is no longer easy, right? You can't just T10 to pelvis or T2 to pelvis and fuse it and balance it out and be done, right? These are kids we're dealing with that have their lives ahead of them, and in some ways you're carrying that burden of what they're going to be breathing like when they're 30 and 40, as you're trying to manage them.
And just the thought is, right, I mean, if you don't have good points of fixation, I mean, the best points of fixation in the spine are the normal vertebra, right? But that means now you're taking, in a 3-year-old, normal vertebra to put in good points of fixation for your VCR, for example. So you don't have those options. So it becomes that challenge of knowing how to balance what we do well as fuse and balancing that with allowing maintained continued growth. So yeah, I'm glad that that's not most of my practice.
Yeah, I know, right? Oh my gosh, how stressful would that be? Anybody else have any questions?
I have a question. Dr. Yaszay, that was a great talk. Thank you. In lines of Dr. Mundus's previous question on these really young kids, when you're already considering a short in situ fusion, when do you pull the trigger, or what radiographic cues are you looking in when you have these young kids that you're already planning a short fusion, when you say this is the perfect time to do it?
Yeah, I mean, I think it kind of goes back to that. I don't know if I would say it's ever perfect, and I think that's what's important, is that in that discussion with the families, I mean, you have to convince the family to go down the route that you want to take them. But I guess I always kind of relate to the family that it may not be perfect. I don't know exactly the optimal time to do the surgery. So it's really related to progression more than anything else. I mean, if it's going to take probably 6, 12, 18 months for me to understand progression. So if you look at the reliability for measuring x-rays, right, even in the digital world, You know, AIS typically normal vertebra is 6 degrees, right? So you need at least 6 degrees for you know, 6 degrees or more to be reliably diagnosed as progression and not measurement error. Those studies in the congenital curve, I mean, they've shown that measurement error can be as high as 15 degrees. So you don't want to just convince yourself based on probably 2 separate x-rays that, oh, it progressed 12 degrees. That means it's rapidly progressing, because you still may be within your measurement error. So I need, you know, 6, 12, 18 months to really convince myself that things are progressing.
Thank you. That makes
And
sense.
mind you, 2 points is a line, right? But so you have no idea what trend is with two x-rays. You need a third. Once you have a third, now you have a trend, right? So having 3 or 4 x-rays plotted over time will show you a lot better whether that's truly different. And don't ever be afraid to stick the x-rays all next to each other and just look at them from afar, like a 20,000 foot view. You're like, okay, wait a second, they do look different just if you have them next to each other. You can gain a lot from just simply looking instead of getting so caught up in the actual vertebrae. But like Burt said, especially in the congenital world, like it's so difficult to measure in general with scoliosis, and then you start adding on like that their bones aren't normal. Like, where do you measure from? And the numbers are weird, and the levels are weird. The end plates don't look normal, so it gets to be challenging. So
10 degrees of you know, measurement error between 2 x-rays, but going the same degree is 20 degrees over a course of 3 x-rays, right? So then you can convince yourself that it's changed.
Yeah. Hey, Burt, when you do these in situs, do you think it's important to take the disc out as well?
You know, to be fair, yes, but probably instrumentation and pedicle screw implementation, I think, has made that a little bit less concerning at this point in time.
Because you're getting a 3-column grab of the bone.
I feel, I mean, even in the sense that, like, even with hemivertebra resections, I'm probably not quite as aggressive on the concave side of getting that hemivertebra, you know, disc out on that side. And I don't generally see continued growth there. I think the pedicle screws are able to kind of hold it, plus the fusion posteriorly. So, and to be fair, the in situs are just not as commonly done.
Well, guys, it's a little after 8. Thanks everyone for being here. Burt, for you for sure. Thanks for joining us. And
well, thank you for the invitation.
Thanks so much,
Awesome.